For all verified facts, subscribe to our YouTube channel and click the bell icon to get the latest updates.
Hello and welcome. Roughly 1 in 2 Indians, almost 47%, live with diabetes and are not even aware of that condition, studies have shown. Only about 24% actually bring it under control. In 2017, there were about 74 million diabetes patients, only next to China, which had about 114 million then. And these, like I said, are numbers that we know about and have been documented. 30% of diabetes patients develop kidney ailments or their condition deteriorates. And diabetes, as we know now, is the cause going into a lot of COVID-19 severity and even mortality. And more so, it is also seen as one of the causes, if not the primary causes, of black fungus or mucormycosis, the outcome of patients who have potentially or likely been over-medicated, maybe with steroids, but that being a secondary part of the case. But the primary problem still seems to be that diabetes lies at the root of this. So this is a problem that we know exists in India. It also has unusual dimensions. A lot of younger people, as surveys have shown, have it, and is a larger problem than perhaps we pay attention to and are also in some ways paying the price for as we try and battle COVID-19. So to understand the role of diabetes in a broader sense, and perhaps if our knowledge of that could help us be better prepared to fight COVID, is what we're trying to get to today. And I'm pleased to be joined to do that by Dr. Nikhil Tandon, Professor and Head of Endocrinology at the All India Institute of Medical Sciences in Delhi. Dr. Tandon is a MD in medicine from AIIMS itself and also a PhD from Cambridge University. He's worked on diabetes care and chronic disease epidemiology. He's also a fellow of the National Academy of Medical Sciences and the Indian Academy of Sciences. Dr. Tandon, thank you very much for joining us. So before we come to COVID, tell us about why or how diabetes has played a role in maybe making it worse for us as a country.
So let me start with a small anecdote so that you can understand how things, as you said, evolve in dynamic. So in the early part of the 20th century, there was an editorial in the Lancet which said what gout is to the aristocracy of Britain, diabetes is to the aristocracy of India, suggesting that this was a disease which was restricted only to those who were affluent and rich. Go 100 years from then, and diabetes pervades everybody. So, the first thing we must understand is that it's not merely, genetic. Clearly, we carry the same gene pool 100 years ago as we are now, but there's a lot of environmental influence and there's a lot of gene-environment interaction possibly happening out there. What has this done to us? And you've given some astounding numbers, and that is a reality. That a lot of people have diabetes, but I think the other point which you raise is equally important to understand, and there is a generally held rule of halves for all chronic asymptomatic or undersymptomatic diseases, that for every 100 people who have the disease, only 50 know about it, right? Give or take a percent or a few percent. That means half the people who have diabetes are unaware of this fact. Half of those who know they have diabetes actually seek suitable medical attention. So we're already down to 25%. And only half of those actually keep things within control. So 1 out of 8 people with diabetes are actually meeting the targets for control, whether it's their sugar, their blood pressure, their cholesterol, or a combination thereof, which clearly predisposes them to a set of potentially irreversible complications. And given the fact that this happens at a relatively younger age, in an economically productive age, that means it has a huge impact on the individual, on the family, on society, but on the nation in terms of its economic impact. If everything has to be translated into rupees and dollars, it is a massive influence on that. So this is an unfortunately sad evolution of a saga restricted to a small minority to now being all pervasive.
Right. And as you look at what you've been seeing in the last 1 year, how would you categorize the role of diabetes in the severity of infections, the severity of illnesses in the patients who've come to you or come to hospital and perhaps in many cases not made it out?
So again, what we've acquired as knowledge over the last year seems to indicate that if you have diabetes, especially if it's long-standing, uncontrolled, and is associated with complications, the odds are that if you do catch COVID, you are going to have a more severe form of disease. You will possibly more often than not require hospitalization. You may require oxygen, you may require ventilation, and you have a higher propensity to mortality. Right, so clearly has a significant, and it's not that the mortality risk increases by 10% or 20%. We're saying it's a doubling of mortality risk, right? So that's 200%. So clearly, but I must specify here, because there's a lot of people who actually have well-controlled diabetes. They shouldn't really be as worried, because well-controlled short duration diabetes actually don't do that badly. It's the ones who've had it for a longer period of time, their body has had to face the onslaught of diabetes for a length, and they've left it uncontrolled for whatever reason. They are definitely at high risk for adverse clinical outcomes.
Right. So, and let me take a step back then, Dr. Tandon. So why is it that we have such high incidences of diabetes in our country, and why is it so pervasive or more pervasive today than it was maybe some years or decades ago?
Right. So I'm again going to share a small vignette. So this is a study done, which is called the India Migration Study, which actually went to industrial workers who are therefore currently urban, right? But they identified those who actually had migrated from a rural background and who had a sibling of approximately in the same age band, and did a whole bunch of investigations there, including looking at whether diabetes prevalence, blood pressure, cholesterol, etc. So remember, if you have a brother back in the village, the likelihood is that you carry very, very similar genes. But the odds of diabetes and cardiovascular risk factors in those who migrated was maybe twice as much as those who had stayed back in the village, right? So same gene pool, but a very different environment. So urbanization, industrialization, which takes away from certain activities of daily living, which previously people used to do. So, in India, when you talk of physical activity, which is a very important part of, preventing chronic non-communicable disease, we were usually involved in work-related physical activity. I mean, leisure time physical activity is not a common construct, or is not a normal part of life. So a lot of people who were doing large amounts of work-related physical activity have now ceased to do that. We've changed our dietary patterns. Urban stressors have come into play. So all of these things, as a result, and then have led to an increase in body fat, whether generalized in terms of overall weight gain or regional in terms of a lot of fat around the belly, which is, again, and that's metabolically very bad fat. So I think all of these are contributing factors. Whether they're the only explanation, I don't know. Whether the genes are interacting with an environmental cue and the genes are getting triggered to do things which they wouldn't have done in the absence of that environmental clue, we can speculate.
Right. And we are seeing a lot of mortality now in rural India as well, particularly with the second wave. Any correlation with diabetes here?
So I don't think we have the data yet. I mean, capturing data on cause of death is a complex story. I don't think we're really equipped to answer, but I think it's a very good question to ask. And hopefully time will give us the answer to that.
Right. So let's look at where we are today. The number of cases are obviously coming down, but we are all now in some ways mentally or otherwise preparing for a third wave, maybe out of fear. But what's your sense? What should people do if they have to, in some ways, be better equipped? I mean, immunity is a very general term for for those who are perhaps already diagnosed as diabetic. Could they be doing something? If you're not diagnosed as diabetic, what could you be doing? And how could you be better prepared so as to at least reduce the chances of having a severe infection were you to get it?
So a quick comment about the sort of third wave. Historically, a lot of these pandemics have had multiple waves, so it will not be inappropriate to keep that and prepare for it, right? Being over-prepared for a situation like that cannot be cannot be a bad thing. And then, of course, the preparedness has to be at the level of the individual and the level of the community and the level of, administrative or governance issues. So that's a broad statement. If you want to narrow this down to people with diabetes or people at risk for diabetes, I think what's very clear to us is that you need to be very well controlled. And COVID is maybe just one more additional reason to make the case for good control. I mean, even if there was no COVID, we would still make a case for good control, because you reduce the likelihood of your kidney disease, you'll reduce the likelihood of heart disease, you reduce the likelihood of retinal blindness. I mean, there's a lot of good which happens by keeping your diabetes under control. And I'm not just talking of sugar at the moment. Diabetes in the broader perspective of glucose control, blood pressure control, and lipid control, and cessation of tobacco as a whole package. So that's very, very important for us, even if there was no COVID to contend with. With COVID to contend with, it becomes extremely important, because if you arrive at the hospital with poor control, we can't undo that prior period of poor control, right? So the ravages of that poor control are now established within your system, and we will have to combat those along with COVID. So it makes life very, very difficult for the medical healthcare provider in that. So extreme precautions, be careful, be cognizant, and there is a need for periodic screening for a known non-diabetic population. And you can do it once a year, you can do it once in a couple of years, because it's, as you said, there's a very high proportion of people who have diabetes. So why is everybody assuming that they're in the we don't have it category? They should test and reassure themselves, or test, and if they find it, address the problem.
And that's only a simple blood test. I mean, it's not like a very challenging RT-PCR test, which also is becoming much more easy now.
No, absolutely not. And remember also, the government has a program called the National Program for the Prevention and Control of Diabetes, Cardiovascular Disease, Stroke. And under that program, for the last 4, if not 5 years, there is a provision for universal screening for diabetes and blood pressure. And obviously urban communities are they can do a lot of this on their own. But I'm talking of semi-urban, rural communities have that provision in government settings, that they will be screened for this even as low as the sub-center level, which is a sub-center is an entity which is located at the level of a village. So there is that provision. People should make use of it.
And Dr. Tandon, what do you advise diabetic patients to do in peace times? And I'm talking about maybe early diabetes or just diagnosed diabetes.
So I actually am very fond of that word, peacetime. Thank you for using it. It's really, I think we need to do peacetime preparedness so that we can combat the wars better. Very clear. So what does a diabetic person with diabetes need to do? If you've got you should get screened so that you know whether you have it or you don't have it, right? Secondly, if you have it, what are the 3 or 4 pillars of care? Obviously, diet and physical activity for me are the 2 foundation interventions, right? You can't eat wrongly and be sedentary and say, I'm going to pop a pill and expect that it's going to do magic. It won't do magic. And diet is, broad principles again: quantity, quality, timing, and spacing, right? So not having large amounts, not eating the wrong stuff, ensuring that there's an adequate spacing between meals, and don't eat at funny hours. Just do your standard, odd hours, bunching of meals, long separation, not good. Physical activity, whatever works for you in your condition, at your age, half an hour walk a day. Medication in consultation with a medical professional, right? And then monitoring. There are people who say, but doc, why are you getting upset that we've not come to you for 3 years? We're taking your medicine. I said, well, that medicine was pertinent 3 years ago. Whether it's still doing its job, I don't know, unless you get periodic checkups done. These 4 things are mandatory for peacetime diabetes management.
Right, and last question. So if you now conjoin this with COVID, now on one hand, obviously many of us are getting vaccinated, so that reduces the chance of let's say getting severely affected, though we might get infected. But if I know today that I have diabetes, and whether I get a vaccine or not, obviously the probability of something the infection getting worse is high. What can I do today to essentially prevent from becoming a COVID patient at any level tomorrow?
Right. So if everybody else is taking 100% precautions, you take 120% precautions, right? So there's no letting up. In cricketing parlance, I keep saying, the batsman has to be lucky with every ball. The bowler has to be lucky only once, right? So you can be very good with your precautions and you let your guard down once. It may be that one unfortunate moment when you get access, the virus get access to you. So you need to be extremely stringent. And, we assume that we're doing the right stuff, but, simple things like wearing a mask properly and ensuring that it fits well around the nose and the mouth is something. Washing your hands, keeping distance, sitting together and eating meals, not a great idea. So, all of that needs to be done. Clearly, try and get vaccinated. I know there are challenges, there have been issues about availability, etc., etc. But, whatever you can do, at least go and put your name on the app, right? There's no problem with that. You must get vaccinated because it'll reduce your odds of getting severe disease. It reduces the chance of hospitalization, reduces the chance of mortality. So I see there's no downside in getting vaccinated. And that everybody should do. What people with diabetes should do much more. And they should not say, oh, there's COVID, I couldn't do this, I've got something else, I'll stop this medicine, I won't. Please don't. Continue your medicines and make whatever effort possible to monitor so that at least if you're well controlled. And if you're not well controlled, you need to reach out to your doctor and take their guidance to get well controlled. And a small message to physician colleagues: if a patient comes into the hospital with diabetes and you ask them and say, do you have diabetes? Comes in with COVID and you ask them they have diabetes and they say no, doesn't make a difference. Still measure their sugars. Because there will be a strong chance that they may come out because COVID can unmask diabetes. And even if they're not diabetic or the sugars are normal on the day of arrival, if their disease takes a turn for the worse or they're given steroids as a necessary treatment, their sugars can get worse even then. So that must be looked at. You must measure so that you know what is to be done.
Let me add one more last question, Dr. Tandon. So, if you were to look back in the last 1 year and look at the way the disease has progressed across the first wave and the way it's progressing across the second wave, what in your mind we've talked about diabetics, and because in some ways that's a known as a key contributor. What are the unknowns or the potential unknowns that we should as lay people be aware of or looking out for, particularly in terms of the propensity to get infected or for that infection to get worse?
So when we look at factors, we broadly categorize them into two things which are modifiable and things which are non-modifiable, right? In terms of one of the important things which is emerging, and I'm sure data will again emerge, is that there seem to be new variants of concern which have come in with this particular wave. Now that's beyond the control of an individual, right? And these variants, it appears, may have been responsible for this rather dramatic. I mean, everybody said that there would be a second wave, there may be, but I don't think, the force of this storm was really anticipated to the same extent. Sure. And not merely the total burden, but with the rapidity with which we accrued people. So it just swamped the system. But that's non-modifiable as an individual, right? In terms of individuals, what is becoming clear, and then maybe a quick word about the new concern which is coming up with mucormycosis, that you need that people. So the mucus story is happening predominantly in people. Well, virtually all the people who are getting mucus today are those who've had COVID, and nearly all, if not a 90+% is happening in those with diabetes, which is uncontrolled, right? So fine, we can't do anything about variants of concern, but we can definitely do something about diabetes. The third thing, which as you also spoke in the beginning, was a thing which needs to be looked in more carefully, is whether the steroids have contributed to this. And doctors obviously will have to adhere to guidelines, but what's also happening is a bunch of self-prescriptions. My neighbor got something, so I would also take that same something. It might be it just helps. Not realizing that a lot of these drugs, while they may be good, have defined times, duration, and doses, and must be taken under medical supervision and not extrapolated from a neighbor's experience. So I think these are the three things which are important for us at this point in time.
Right. Dr. Tandon, thank you so much for joining me. Thank you for sharing your insights, and I do hope to speak to you again as we hopefully conquer this dreaded disease. Thank you so much.
Thank you. My pleasure.